Thank you so much. By the way, Moses is so excited about this panel that not only does he expect you to solve it, but he expects you to do it in this 40-minute session. So no pressure.
We'll have time left over.
Good. So the first time I spoke at this conference 5 years ago, I took some bandages out of my arm and came here directly from Princess Margaret Hospital after a chemo treatment for pancreatic cancer. All I remember was that I was in a fog, and I was never before or since so happy to see that clock run out and tell me to stop talking. Last April, my mother-in-law, Evelyn Gould, died a month before her 99th birthday of Alzheimer's disease. And before that, she had been receiving compassionate and affordable care for 7 years. So to reveal my bias and to paraphrase a very rich and famous baseball player, healthcare been very, very good to me. But that's not the case for everybody. If you ask most people in the street what makes you Canadian, one of the first answers they'll give you is our healthcare system. But as our first panelist, Andre Picard, points out, we love to whine about our healthcare system. So Andre, take it away.
Great. Well, I'll try not to whine too much. So our healthcare system is about 55 years old officially. So it's a Zoomer. And some people think it should be retired. I think it should be rejuvenated, that it's only just begun. So I want to talk about how do we bring about longevity to the system. You know, we've talked about the individuals. So how do we make this system survive longer? And I'm a print journalist, so I cheat a bit. Before the BlackBerry came the file card. So sometimes I'll refer to my little notes. But I think we have to emphasize that our medical care is really good when you get to the right place. So we have some access problems, but mostly we have engineering problems and administrative problems. We don't have a medical problem in Canada. So it's, the issue is fixing the system, making it better. So I think there's 5 key issues that we have to deal with, and I'm going to go over them very quickly to stay on time. So number 1 is I think we need to emphasize primary care. Keep people healthy, do prevention, essentially turn our system on its head. We have very much a hospital-based system, and we should have a more community-based one. And that's number 2. Treat people where they live is really essential. That means more home care, more community clinics. When we have institutional care, it's sometimes required for things like Alzheimer's. More, I think, small-scale facilities is what we should be looking at, right through to palliative care. Number 3, I think we have to deal with our drug issue. We have a universal healthcare system, but it's not universal enough. It excludes drugs and home care and things. And drugs is a real sore point. There are people now in Canada who are still losing their homes to pay for their cancer drugs. That offends the principles of Medicare. That's not what's supposed to happen in Canada. 4th, I think we have to emphasize a lot more what makes us healthy. And that's not necessarily medicine. It's having a good income, it's having a roof over your head, it's being part of a community. You know, in Canada, loneliness and poverty are big killers, and we have to address those, especially in the older population, in the seniors. Finally, I think we need to start talking about a vision. I think we've lost sight of why we created Medicare. People of a certain age will remember that we created it out of need. People were suffering unduly, so we created this system to bring together our economic forces and social forces and create a system that was more fair. So what's the vision for the future? I think it's the same one as in the past, which is we want a system that's accessible, affordable, effective, and safe. And for the money we spend, about $207 billion a year, we should be able to do that. So in short, in brief, to recap, we have this system was created in the 1950s in the image of our population at the time, a young baby population having babies, needing only acute care. Today we have an older population that needs chronic care. So we have to reshape the system in the vision of the people it should serve. Thanks. 2 seconds to go.
2 seconds to go, perfect. Okay, keeping up with the theme of whining about the system, Susan Eng, Carp's Vice President of Advocacy, has often referred to herself as the whiner-in-chief.
Well, you know what they say about the greasy wheel, the squeaky wheel getting the grease. Besides, in my job in advocacy, my slogan is call me anything, but just call me. And that's the key here. The people we focus on are our members, 300,000 members across the country, all of whom are focused on three major priorities. Pension reform, not outliving their poverty. Healthcare is always top of mind, and of course, the rights in everyday life to keep working, to be free of any kind of abuse and fraud, and so on. So when we talk about healthcare, who are we talking about? These are the people who are the healthcare consumers. They're the ones who are, in this generation, much more involved in looking after their own health. And so they or their families are the ones who, when there's an acute incident, somebody falls, somebody has a stroke, they're the ones that have to access the healthcare system, and they are running from pillar to post. So Carp has a policy, a position paper called One Patient. Pretty obvious. There's only one of us, and we're trying to figure out how to reach the different silos of the healthcare system in quick fashion, because nobody really spends their daytime hours thinking about how they're going to plan for their next medical event, right? So we need a system that organizes itself around patients, patient care, creating a seamless, continuum of care, from first diagnosis to acute treatment and to aftercare and palliative care. There's not a lot to ask of a healthcare system on which we spend, what is it, Andre, 190 billion?
277 billion last year.
270 billion, the last time, $277 billion of your tax dollars. And there's always a complaint that as the population ages, somehow older people are responsible for all of this and that they're blamed for this expense, right? And of course, the experts are always telling us it's increased demand and the increased cost of treatments that's driving the cost up, not because we're getting older, as if that was a bad thing. Besides, if we are the cause for spending all this money, then we should be treated a lot better. Then a lot of us are noticing, as all of you, I'm sure, are either facing times within the medical system or helping your families through it, and I see lots of nods in the audience, the system could be so much better. There's no need for this. There's no reason why I just can't go to the hospital blood clinic and get my test done while my mother's waiting for a dental appointment, but they say they can't do it because my doctor doesn't have privileges at that hospital. Why not? It's the same payer, the same computer system. So this is what we're dealing with, and when you start hearing doctors and hospitals and other systems say, we're going to do something new. We're going to create patient-centered care. You got to ask yourself, what was it before?
Thanks, Susan. Next, we're going to hear from Domenic Pilla, who is the CEO of Shoppers Drug Mart, and he has some very specific ideas on how to make the system more efficient, take cost out of it, by using professionals like pharmacists. Domenic.
Thank you, Libby. So I will be a little controversial. It is because we're getting older. And that's not about the patient, that's just a mathematical fact. In a little over a century, our life expectancy has almost doubled. And the system was designed 55 years ago. And so that's a mathematical fact, is that 14% of Canadians are over 65, but they consume about 45% of the costs. So it's not about the people, it's just a mathematical fact. And the system is straining under that reality because it wasn't designed for that. The other thing that the system is straining under is the fact that it is acute care-based. It's hospital-based. It's a hospital-based system designed for younger people that had car accidents. The reality is that a majority of the costs are in chronic conditions. And as Andre would say, the point of care, or where people get care, is not properly designed. It's not the right architecture for our reality, which is chronic conditions are driving the majority of our costs, where the majority of our investment is in acute system. So structurally, the system is not designed for our reality. As Andre says, a big part of that is around primary care reform and the ability to change the point of care, not only the point of care, but the way that people are looked after in their primary condition. And we believe that pharmacists are uniquely positioned to provide some of that care, however, in a multidisciplinary fashion. And it really is around a multidisciplinary approach, we're absolutely convinced, and we have a tremendous number of examples, that under those guidelines, you can actually lower the cost of healthcare. It isn't about the money. It is not about the money. We're investing significant in healthcare, and there's enough money in healthcare. It's about the organization of care, and we can save money and have better clinical outcomes and actually have people better. And we are convinced about that, and we've written a paper. We co-authored a paper called 9,000 Points of Care, 9,000 referring to the number of pharmacies in Canada. So it's not just about Shoppers Drug Mart, it's the entire pharmacy system, and how expanded scope of practice, taking clinical people that we've trained, and we spent money training them, using their clinical knowledge in a multidisciplinary environment so that they can provide care to patients in a way that results in them having better clinical outcomes and lower cost to the system. And we think there's tremendous opportunities to do that. And the other avenue that we think is new and new breaking ground and, is around wellness and prevention. And again, the root of our problem is we've been working on the supply side, providing care, as opposed to the demand side, which is getting people having the condition in the first place. And of course, we're very proud of the fact that with the combination with Loblaw now, a big part of that is around nutrition. And so we're absolutely convinced that nutrition is a component of wellness, which also will help our healthcare system.
Thanks, Domenic. Dr. Louis Francescutti, I hope I said that well, is the newly elected president of the Canadian Medical Association. And he says that the doctors should stop whining about the system and become part of the solution.
Well, I think everyone should stop whining and get down to action. So with my graduate students, I tell them, if tomorrow everyone woke up in Canada and there was absolutely no disease whatsoever, how would we spend this $270 billion to keep the population healthy? And the last thing you would build is a healthcare system, because a healthcare system really only contributes about 25% of your health. 75% of your health comes from the social determinants of health and the environment and your genes. And people have to start realizing that if we want to start talking about healthcare, we really should start talking about health. And that if there's a 17-year-old girl that's pregnant with her third child, then the stress in the life of that woman is translated to the genes of that fetus. And that fetus will then translate those genes to the next generation. So that by the time you have 2 or 3 generations of folks that are really down and out, it's ingrained within their genes. The things that make people healthy are very simple. 3 risk factors, smoking, inactivity, and poor nutrition, contribute to 4 major diseases: certain cancers, diabetes, chronic pulmonary, and chronic respiratory, as was mentioned, the chronic diseases. And those account for 50% of the disease burden, 50. So 50% of the reason why we need a healthcare system is according to 3 risk factors. And the speakers that were talking this morning have got it right on. It's not very complicated to keep someone healthy, but it's a lot more expensive to take care of them once they get, either with a chronic disease or injury. So how would we go about changing a system like this? Well, we call the system out. The system doesn't have very good governance right now. It doesn't have very good accountability, and we have to engage in the crucial conversations that we're doing right here. Once we do that, then what we have to do is say, where can we get money to invest in the system to make it better? And the first place is reducing injuries. Injuries are the leading cause of death for Canadians under the age of 45. Motor vehicle collisions are the leading cause of death under 35. And Australia showed us that you can get a $22 return for every dollar you invest in traffic safety. So if Canadians would be prepared, we could get an enormous amount of money up front to then not only take care of the people that are in the system now that we have to take care of, but to plan for the next generation. And if you think you've got problems now, there's a tsunami of disease coming down the pipeline. With the levels of obesity we're seeing in our kids today, you haven't seen disease till you see that reaching middle age. Our kids will never live as long as we've lived. Our kids are going to die before us. So let's engage in that conversation. There's 80,000 physicians out there that are not quite satisfied with the way the system works. Andre's absolutely right on the money. The level of care, once you access it, in Canada is second to none around the world. The problem are access issues. So it's a solvable problem, and this is the start of how we solve it. But let's stop the finger pointing. It doesn't serve anyone any good.
Okay, well, let's start. Let's start the discussion with you, Dr. Francescutti. I've heard you say to audiences of physicians that unless physicians step up, they will lose their privileged position in the system. So I'm asking, shouldn't they give up some of that privileged position in the system to make everything go a little smoother?
Well, I didn't say that. It was the Governor General that said that. The Governor General basically said that society has a contract with physicians, and physicians are not living up to that contract. And unless physicians live up to the contract that society has with them, that contract will be rewritten. And that contract is about to be rewritten. And so my challenge to the medical profession at General Counsel was, there's never been a greater opportunity for the profession to shine than now. And now what we have to do is take the excellence that we know is going on around the country, but unfortunately it's going on in isolated pockets, and bring that out. So we have to add accountability for everyone within the system. Our politicians need to be accountable, and patients need to be accountable as well. We've all failed to meet the accountability that we should be meeting as individuals.
What does that mean on a practical level?
Well, being accountable for an individual means, taking care of your health. You do have some responsibility. We often forget to talk about that. We talk a lot about our right to health care. We'll talk about our responsibility. For physicians, what does it mean? It means the social contract is that we've given you this power and privileged status, and in return, you are serving society. You're not just there to earn an income. Yes, they should get a good income, but there's a greater public service. And it goes on down the line. For politicians, it means don't just sit back and say, ooh, these are uncomfortable things to talk about. Tackle the tough issues. I just finished a book about healthcare reform. I went back and read all our public inquiries going back to 1961.
Oh, wow.
And
you deserve a hand for that.
Well, the simple conclusion is they all say exactly the same thing. We've known for 50 years what needed to be fixed, how we needed to stay ahead of the challenges, and we just haven't done it. And that ultimately falls on our political leaders. There's a lack of leadership there. Okay,
so where should we start?
Well, I think there actually is, as Andre says, actually quite a bit of raging agreement on what the problem is. This thing about chronic conditions, aging population, silos. And it's been, people have tried to tackle it. I think the one area that we're very uncomfortable with is around aligning incentives. So accountability that you've talked about. And it starts with the patient. So we're very uncomfortable with co-pays, for example, to influence behavior. Wouldn't it be interesting if you had to pay more if you showed up with a car accident and you weren't wearing your seatbelt? And you had to pay more because you have to take accountability for your actions. What about smoking and so on? And so would we be comfortable to align incentives? And what we know is incentives actually influence behavior. That's an economic truth. It's a 101, economics 101 truth that incentives influence behavior. What's the incentive for a physician to prescribe a lower cost therapy for the same outcome? There is none today. There is no influence of cost to therapy, and there isn't that link. What about incenting physicians for outcomes? Or all health professionals for outcomes, including hospitals? Why aren't they given a budget based on clinical outcomes as opposed to number of input patients? And so aligning incentives, in my mind, is a critical component of having an efficient system, and it helps break down the silos, which is another critical problem. Starting all the way from the patient through to the provider, what's the incentive for an employer to hand over to the public payer a healthy retiree? There is none today, none. Zero incentive to do that. In fact, what you find is adherence to medication, for example, or therapy is not encouraged by employers because it costs more during the time that people are working. So why would they do that, as opposed to they know that ultimately the consequence of that action is in the public purse after people retire. And so there's no incentive. And if we could align incentives down the road, I think we'd get significant economy for better outcomes and help break down the silos, creating a multidisciplinary approach. And I think that's a big part of the solution, but politically it's a difficult one.
Susan, does that sound too scarily private sector?
You know what? It sounds way too jargonish. And from the perspective, of the user, the healthcare user consumer, our members are retired teachers, university professors, doctors, lawyers, accountants. They are educated people. We probably have some rocket scientists too. Yeah. But when you come up against the medical system, we're all babes in the woods. We have no idea, actually, what should happen next. So there used to be a time, and I think the time has already passed, when we thought doctors were gods. I have a brother who's a doctor. Full disclosure, I don't think he's a god. So that colors my view, I'm afraid. But the point here is that then, in the absence of good information, they look for other information, on the websites, through the, alternative medicine. Everybody's trying to fix their lives, fix their body, and they don't have all the information they need. And this comes really to play at end of life when they don't know what are the limits of medical science. So in the social contract that we're talking about, the most important ingredient is informed consent. And we get assumed consent because you're too weak to say no, but you certainly don't have informed consent, you don't have active consent. So if we're going to build a social contract where everybody's in it, as Domenic has said, and we realize that if we don't prevent illness now, the system, all of us, our taxes, our families will pay later. If we take that perspective and magnify it into how the system works, how the healthcare system works, how it is accountable, how doctors are accountable for the health of their patients. Maybe they get paid more if they all get cured, or if they all stop smoking, or if they all lose weight, if they drop their blood pressure. If their pay is actually calibrated to the health of their patients, maybe we have accountability, but that's the way the system should be funded, should be accountable, and the only way you're going to get that accountability is that average citizens know what they are entitled to, what can be done, which part of the system they have the pressure to get this change, and we tell everybody at the same time so they have a chance to actually influence the system.
But, if you try to put in the basic blocks of accountability, it's a huge pushback. I mean, even something like making a different payment requirement for employees who smoke, that's not going to fly. Or, there's even a feeling that a lot of lung cancer patients, they get blamed for their illness, so that's all different.
The victim, to some extent, their own inadequacies may put them in this position. So people balk at that because they don't want to be treated, not be treated fairly. And we get that from a lot of our members who are older, who say, you know what, I don't think I got all the options because of my age. I don't think I was offered the opportunity to do X or Y. One man wrote to us and constantly, my wife died in this hospital, and I know she could have lived longer had they done this. I don't know if he knew, but he certainly believed. And so we have a role to play to level the playing field of knowledge so that when we give our consent, we know what we're consenting to.
Yeah, but
I think you're quite correct that we live in this information age and we do a really bad job of health information. We don't, and it starts to me right at childhood. So take our schools. Our schools are factories for creating unhealthy citizens, right? We take kids and we sit them on their asses all day and we tell them, oh, don't move. And don't go to recess, do a little extra homework, and go home, don't go outside, it's unsafe, which isn't true. And then do more homework. It starts right from there. We're creating an unhealthy lifestyle, and we're doing it, it's as if the education system doesn't know the health system exists, and vice versa. So there has to be much more integration of
Yeah, but it does start with accountability, and I know it's a hard message, but
Well,
we did a test, a test with an employer and an insurance company, and it's about 1,000 patients. These are diagnosed. They've diagnosed diabetes patients. They know they have the condition. They're followed by an endocrinologist. They're followed by their primary care physician, and they're taking medication to control their condition. 50% of them, when we did the test, had their condition out of control. 50. We know clinically that because they're not managing their condition well, their morbidity, their effect on the healthcare system is significantly higher than the other 50% who were managing their condition. Now, some of them were doing it out of choice. Some of them were doing it because they're better educated. Some of them were doing it because they believe in it. Doesn't matter. It's the consequence of those 50% that are not managing the condition is a huge burden on the healthcare system in that example, in terms of blindness, in terms of amputations, in terms of emergency room visits. It's huge. It's significant. It's orders of magnitude higher. Now, what should we say as citizens? There are co-citizens. You have 500 people that do a good job, manage their conditions. They're going to nominally cost the system. We have 500 other people diagnosed, followed by a physician, who choose not to. They choose not to follow their plan. They're going to cost the system 10 years from now significant dollars. As a society, is that okay? Is that okay as a society?
What do we do with them?
Well, I don't think it's I think incentives work sometime. Accountability is important, but I think you have to look at people, a larger part. A lot of people, why do they not follow what their doctors tell them? There's all kinds of other reasons. Maybe you're a lonely senior who doesn't have any food. You have all kinds of other stuff going on in your life.
Employed people.
Let me just
100%
just
employed.
interrupt just to, I can't, I'm trying to remember the number of people who do not follow their prescriptions the way they're given out. Isn't it
If you
huge?
write a prescription, 30% never fill it, 30% sort of fill it and sort of use it, and 30% fill it and use it correctly.
Yeah, so adherence, which is the terminology, the jargon, I'm sorry, to that is pretty bad.
Is that
But-
because
but-
people, A, can't afford it, or B, if they get it for free through a plan?
No, I think there's a mix of that, but the example I used, we tried to take away other reasons. These are 100% employed people, 100% young people, so I'm trying to illustrate it. There's a component of that is accountability, and incentives are a component of that. And it's not that I ignore the other components, I agree with you.
So I'm a scientist. I like to base things on fact. And so Intermountain Health in the United States, Kaiser Permanente, there are large groups of organizations that do this and do it very well. So, people shouldn't think that the world's falling apart. It's not falling apart. If you were to have a heart attack today, someone would pick you up, probably give you thrombolytics, take you to the local hospital, and they do a great job. If you get hit by a car getting out of here, ask to go to Sunnybrook. They'll do a great job putting you back together. So the acute care part, we do very well. Yeah. What we have to do now is model after other centers that have done this and done it very well, and that the patients are very satisfied, and do it in a publicly funded system. Ralph Klein, bless his soul, brought 36 experts from around the world to sort of say, yeah, we have to do it the third way. 36 experts from around the world came together and said, no, the third way is not the right way. Do it your publicly funded way, but introduce accountability into the system. And that's what we're talking about today. We want to introduce accountability into a system that unfortunately is not loved by anyone. Somebody was talking about love. Rarely do we talk about loving these healthcare systems. These systems are very complex. That's the most complex thing within our society is a healthcare system. We have to start saying we love these systems. We have to teach the people that work within these systems to love the system. And once you start loving these systems, then it becomes natural that you take care of the people that are in the system, that both work in it and are served in it. And I don't believe in patient-centered care. I believe that the patient should be removed from the equation. I think as long as we continue to talk about patient-centered care, we miss the point. The majority of disease, and other speakers have said this, is totally preventable. So let's break our addiction to disease treatment and really move our mindset to where we have to go. And that's a real paradigm shift that you won't get there unless you start talking about it. And it's not good enough for one of the world's best health reporters to talk about it, or the president of the CMA. The people that are going to make the difference are sitting right here. It's the boomers, zoomers, call them whatever you want. If they mobilize themselves and make it crystal clear that enough is enough, we're proud of our system, but the system has to be taken to a different level, then it will happen. If you don't say anything, it's not going to happen.
But, okay, prevention, right? One of the things that I report on incessantly, exercise. Exercise, if there was a magic pill for anything, it's exercise. I'm sure that's one of the main reasons I recovered. But you still can't get people who don't want to exercise to exercise.
Well, that's easy. Kids should be bused to school and dropped 5 kilometers from the school.
Okay.
And they walk the last 5 kilometers. We have Generation X, yes. We've got Generation XXL coming down the pipeline. We've got to do something about it, seriously. Because we know the benefits of exercise are directly related to your ability to learn, directly. John Ratner at Harvard with his book Spark showed that conclusively, and for you as well.
But okay, focusing on us, on Zoomers, and we're getting older, and we're going to have more health challenges. So what does it mean for our generation?
Very simple. Sleep 7 to 8 hours a night. Take 10,000 steps a day if you can, or the equivalent, swimming, whatever. Eat more often, but eat less, and chew your food 40 times. And if the food you're eating won't rot in a couple of days, don't eat it. Like, why would you eat food that doesn't rot?
So one of the companies we admire is Kaiser Permanente. We think they've got their ecosystem, because it is an ecosystem, our healthcare system. It runs very well, and it's actually a great model for a publicly funded system. So this isn't about private-public. It is actually a great model for publicly funded system. However, what I'll tell you is they've made some of the tough choices around incentives, very tough choices. And if you're part of that system, and the entire ecosystem, so their hospitals, for example, get penalties for readmittance. Penalties for readmittance. If you don't treat the person properly and they have to come back, you get penalties. Physicians are incented for the lowest cost therapy for the best possible outcomes, and we measure outcomes. They measure outcomes. We don't in Canada.
And physicians are happy working in those systems.
They actually are very happy working on those systems.
Just a point. So a lot of readmissions in our system, if you're especially looking at older people, is because there's no place for them. They keep going back.
There is a place for them. It's called home.
Yeah.
You could spend $50 a day supporting someone in the home,
Yes.
as opposed to spending like $300 in a nursing care or a couple of $1,000s. The best investment you can make is have people age within their home environment. Absolutely, it's the
Hallelujah.
most cost-effective thing to
Sounds
do.
great, but it's not happening. And that's the problem. You know, it's great in a model, and it's great if it happens. But in actual fact, when people have to be discharged from hospital to get home, their home's not age-friendly. They have to get from the hospital door back to their own door. They're not ready, and the system is not helping them. They are not going to be guaranteed to get home care workers in their home when they get there. They can't rely on it during the week. That's what's happening. It's a nice thing to say, but it's not happening. And so who should we talk to get this to change? Domenic mentioned earlier that there are half the people they test are not complying. Are they just stupid? Are they really committing suicide slowly? Or did somebody not tell them how important it was to keep up the medication, right? So this is the kind of thing that these are wonderful ideas, and they've been talked about lots, you know, running. Sure, both legs are working, you know, but in exercising, the key here is that people, you have to address them where they actually live, their actual lived lives. And the kinds of ideas that we have to manifest for real.
Oh, but
you know,
they are.
this is not bizarre.
Maybe you're just not aware of them, but there's thousands of examples of things that are
fully
working in
aware
this
of-
country.
Well, that's true, but it's not covering everybody. You know, we have percentages.
Or enough. I mean, you
We
can
don't have
need
enough, and that's the point.
40
you know?
hours of home care, and they say, well, you've got 2 hours a day.
Yeah, and so what should you do for the rest? So the
Exactly.
point is that if we're going to do this kind of thing, the system not only has to turn on its head, it's got to actually move forward and recognize that it's not that we just want to get percentages up, because what do you do for the ones that are left behind? But you actually lift everybody up so they all have access to, you know, at least the most basic of help at home and understanding and the knowledge and the information. So I think that what we have to do is take some of these great imaginings and make them real.
But
Yeah,
they're
so
not. But they're not imaginings.
In Canada, we've solved all the problems on a very small scale. We're this land of pilot projects, and that's really our challenge today. Our challenge is to scale up and to make these solutions universal solutions. So
Okay,
we've
And they're not
resolved
imaginings.
everything.
I mean, they're really not imagining. There are tremendous examples in Scandinavia, for example, around home health as a solution. So they're great working examples. They're not imaginings, and there's great pilot projects in Canada. So the question is, how can we build a scale? And not is it real? These are real. These are not hypothetical. They're real examples within Canada and also outside of Canada.
Well, it's not happening because you guys aren't asking for it. It's as simple as that. Politicians will go where the public wants them
That
to
I
go.
can fix.
Okay.
If you ask for it, you'll get it. If you don't ask for it, then we'll have these bitch sessions every year.
Okay.
Nothing will change.
Before,
Bitching sessions. I didn't.
whining,
you know, I didn't-
whining. Pardon? Wait a minute. Okay.
Neutral.
Thank you, Susan. But, okay,
Yeah,
so.
I meant whining. If they could edit that. Where's that gadget guy? He must have a gadget.
Before we leave the stage, though, I'd like to get a sense of what each of you can do when you leave here and you go back to your professional community. What are you going to do to make
Well,
this
I was
happen?
in Sault Ste. Marie last night talking to the Northern Ontario School of Medicine, and I'm telling them we've got to embed this within our new learners And we've got to really get 80,000 physicians that really understand what's going on. And unfortunately, 80,000 physicians, this is where I get in trouble, don't really understand what's going on. I think they're getting ready to, and I think they're being challenged to, but I think the profession's going to respond. The Governor General woke up the profession, and the profession is now saying, okay, look, we've been doing this for a long time, maybe we've gotten a little off track, but let's get back on track, work in these teams, use the expertise of our pharmacists, our nurses, our paramedics, and others, and let's put the pressure on the government to say, $270 billion, you must be kidding. We're spending that for this kind of outcome? That's not a good return on investment. And organizations like yours should be keeping, everyone
Honest.
Yeah, honest.
Okay, Susan, what whining are you going to do
the name
tomorrow morning?
The name of our organization is Carp. The legal name is Canadian Association of Retired Persons, but in this context, Carp works, right? And the key here is that we're actually catching a moment. We're getting to the point where the boomer generation is just reaching that time in their lives when they are confronting the medical system. It also happens to be the generation is not going to take no for an answer. They are computer literate, they're politically literate, and they're politically engaged. And the evidence has shown people over 60 vote all the time, period. Mm-hmm. So part of our work at Carp is to make sure what they're voting about, to unpack all of those politicians' comments, people talking about patient-centered and so on, and say, you know what this actually means in your own lives? And here's the name and the address and the email address of your local minister of health, local minister of finance, which is important, and go sick 'em.
Domenic?
Well, so first of all, the system is not sustainable. We shouldn't hide from that. It needs a transformation. I actually believe it goes by dealing with the demand side, not the supply side. So not providing care. It's about avoiding care in the first place. It's around disease management. It's around wellness, nutrition, all that stuff. The system has to be transformed. And we certainly want to be part of that solution. Pharmacy, the community of pharmacy wants to be part of the solution to allow us to have better clinical outcomes at lower cost. We believe in it. But it will require a transformation. And what I'll tell you personally, this is not a public, but personally I believe it actually stems from aligning incentives, including patient incentives or penalties for behavior. And it's just going to be a necessary component of the reform.
Okay, Andre.
I think what isn't sustainable is the status quo. So there's no question that what's important to us, the most important thing in our lives individually and collectively is good health. So we have to make it work. It doesn't have to be what it is today. So I'm going to go back and keep poking away, writing my stories, and doing a lot of reminding people of important history. So our Medicare system was born when baby boomers were born. It was born in the baby boom. It was created for that generation, for their parents and grandparents. That's not an appropriate model anymore. We now have to create a model for people who are now boomers. Chronic care system, treat you in the community, make it affordable, accessible, education, give you the power to have control over your lives, because that's what boomers want, and that's ultimately what the system should do.
Okay, well, I think that if any generation can do it, our generation can do it because we have transformed the way we do everything, basically, and we like to have our way. So I guess that's a call to action for all of you. Thanks so much. I'd like to thank the panel, our fabulous blue chip healthcare panel, Dr. Louis Francescutti, Andre Picard, Domenic Pilla, and Susan Eng. Thanks a lot.
Thank you.
How are you? I know you have to leave to catch an airplane. And I know that
I'd rather not catch it and walk on it.
We've generally had this discussion at a very high level. And I want to ask a more practical question. I've been persuaded, I've listened to Domenic now twice. In fact, I met him on the occasion of him participating in another panel discussion. And he said, it seemed to me, some very persuasive common sense things, having to do with reducing the cost of care by simply getting it done on this local level by people who perhaps were not as specialized and not as costly and not as hard to get to. Simple stuff. I wrote it down at the time. what we're talking about, flu shots, inoculations, minor ailments, hay fever, back pain, screening for arthritis, prescription renewals. Is the problem this question of turf protection? I ask the question in all innocence because I want to understand what is it that prevents these good ideas from actually getting implemented.
Well, the biggest thing we need in healthcare today that we don't have are seasoned, experienced grandmothers, because our seasoned, experienced grandmothers would take care of a lot of the ailments that existed in the past. So we live separate lives. We don't have that. What are patients left to do? In the middle of the night, you've got a fever, and you know, the industry's convinced you that the fever is going to kill the kid. You're not going to stay home. In the middle of the night, you can't get a family doctor. You have to go to emergency. So the system's not designed properly. Teams, I think the medicine of the future will be very different. You'll walk into a room, if you have to, and some big computer is going to make a diagnosis. These gadgets are going to confirm the diagnosis, and you'll be shepherded to a team, and that team will specially take care of that condition. So we're going to be using full scopes of practice, and we'll probably need less healthcare workers, and we'll get better outcomes at the next of the day. Stay tuned. The technology is evolving so rapidly that if governments actually say we're going to do something about this, what I would do is I'd take Prince Edward Island and say, let's do a big experiment and make Prince Edward Island the healthiest province in the country. And if we can do it there, then roll it out. But there is turf. If you were to redesign the healthcare profession today, it wouldn't look the way it is. It's not designed to meet the needs of society. It's designed to meet the needs of the healthcare providers. And disease doesn't only work Monday to Friday, 9 to 5. The disease that I know works 24 hours a day, but the system's designed Monday to Friday, 9 to 5.
But is there a Tsar with the power to unlock the problem?
Right here.
It's
I'm
very
serious.
diffuse. It's
No,
very diffuse.
no, you've got to
They can write
mobilize.
letters. They can plead through Susan Eng.
I'm convinced
we can submit
it's going to come
papers.
from this generation, as Libby said. You have the voice to make the change. We've been trying as hard as we can for many years. The system is slow to change. This is a revolutionary change that's required. It's not peace. It's not peaceful.
Part of the problem.
Well, that's what I'm trying to get at, and I'm trying to figure out, is there an answer to how to unlock this problem of jurisdictions, not only geographic and political, but also professional?
But this has been powerful. This discussion is the start of something, and I hope you continue it, because this is powerful. This is good. You know, you're getting to the meat of the issue. This is an important discussion you started here today.
Well, we are making progress with policymakers in terms of understanding that they need to leverage the entire system. But it starts with, I think, if we're going to communicate something, it starts with, if we're going to be patient-centric, the point of care, where you get care, has to be a component of that. And right now it isn't. You don't have a choice. You have to go to the emergency room. There is no choice. And regulations prevent other professionals. So we're now doing infusions in people's homes with nurses, telesupervised by a physician. It's a great, actually, it's a great protocol. But initially, I have to tell you, it's lots of resistance, and it's only allowed in some jurisdictions in Canada. Because and those jurisdictions were able to break through because there was leadership. In other jurisdictions, we can't. But that's a great clinical protocol that costs less and actually has better outcomes.
You know,
Domenic, the barrier is a law?
In some cases, it's regulation. In many cases, it's both. It's practice and regulation. You know, flu shots. So yesterday, I was with the health minister of Ontario in one of our stores getting my flu shot. Health minister got her flu shot in one of our stores. It is there's tremendous evidence that getting your flu shot by a pharmacist in a pharmacy at any hour of the day, it was a 24-hour store. We staffed that store ready to receive something on a walk-in basis, 24 hours a day, 7 days a week. Clearly, that's a better opportunity than for people that are working, for people that have young kids, whatever.
Sure.
Great idea.
Is there something that stops
Yeah,
that from taking place?
but only available in the last 2 years. Should have been available for 25 years. But for the last 2 years, we finally, in Ontario, breakthrough was we allowed pharmacists to give flu shots. And so there was a regulatory barrier. And so as we speak, great evidence in the US, great evidence in Europe, tremendous evidence now in Ontario, that's the right thing. We did more flu shots in a week this year than we did in an entire season last year before it was allowed. So great idea. 6 provinces in Canada don't allow it.
Well, we can do that. And it would help if everybody became a Carp member and go back to your respective provinces and put pressure on them.
That would be an easy example. Right now, there's 6 provinces in Canada that by regulation interdict that highly evidenced great protocol
And
of
the
providing
motive-
that service.
The motivation would have at one time been that pharmacists don't know enough to do it?
It varies by province, but it is around turf, to your point.
Libby?
I just want to mention something Domenic and I were talking about before the panel. So you mentioned, if I may say, that there was a bit of a supply problem with the vaccine because it's a different authority that handles that, public
back to
health.
silos.
So it's so complicated that you don't even know necessarily, or it's difficult to find out who has the jurisdiction for what you want to do to unbundle this. And so that makes it very complicated because first you have to figure out who to whine to.
Our position is, you know what, sort it out among yourselves, because I don't actually care about your jurisdictional problems. You know, what
Right,
we
but
want
if
to
you go
do
to
is
the wrong
turn
person,
around
they
and
can't
say,
help you.
you tell all these people what your problems are and see if they can be bothered to listen to you tell us why you can't do something.
But I would say don't just talk about the change and demand the change, live the change. So I write about this stuff incessantly. I feel I have to live it. So I keep myself healthy. I get my treatment from a nurse practitioner. I've sought one out. I only see the doctor when it's necessary. I get my flu shot at Shoppers Drug Mart. When my mother was sick, we insisted on nursing home, not a nursing home care, but home care. Took a lot of phone calls, a lot of fighting. But you got to push at the individual level if the system's going to change. You know, the reason we got Medicare was because there was a need. The need still exists today, and we need a different Medicare system. And it's going to change the same way it changed before.
Can I give you one last piece of advice? Don't let a healthcare provider touch you unless you see them wash their hands.
Boy.
Yeah. But it is, so one of the things that we think is certainly personal accountability, but the other component of it is multidisciplinary. So we try to now, so when we have those conversations now, we were naive as well. Having our conversation with great evidence to a regulator wasn't enough. Bringing pharma companies, physicians, hospital administrators, public health officials in the same room, having the same conversation with the regulator is a much better, richer discussion. The regulators is much more persuasive because actually we have raging agreement when we get together. It's when we work in silos that we have a problem. So breaking down the silos, and we do have that responsibility, and it's certainly our model, is we actually only advocate now when we could bring a multidisciplinary approach, because typically actually we do have agreement, and it's much more difficult for the regulator then to not respond. And clearly if we could have the constituents as part of that, it's a huge advantage as well.
Thank you, that was great.